All right, well, welcome. Thanks everybody who has come in the room. We have about the same number of folks that are joining us online right now. Uh, I'm Paul Estabrooks. I'm a professor in health and kinesiology and work on the Dissemination Implementation Science Core for the CTSI. I also direct the Mountain West Prevention Research Center that is a D&I focused center trying to improve physical activity, healthy eating, and weight control in rural communities across the Mountain West. So that's me. I will let James introduce himself when he comes up. But I'm just gonna jump in with a quick reminder. If you do have your calendars open, it's always good to save the date. We're going to do our next session will be the end of January, which is community engagement and dissemination implementation science. And that's going to be led by Jenny Hill and Chelsea Schlechter. And so both of them are folks that have a ton of dissemination and implementation science experience, and both of them deeply embedded in community work. So it'll be great. And then also, if you want to put on your calendars, April 11th, we're going to jump into hybrid designs. And we know for sure, is it going to be JD and Liz? We'll be doing that. So that'll be awesome. So yeah, pop those things on there. Um, we're going to talk today about, we're still in the introduction phase. How many people have been to the earlier workshops? Raise your hand. Okay. We got about a third of the folks in the room. We are stacking these a little bit, so you'll hear some concepts that we've talked about before. Just for those who haven't been there, we have had a previous workshop on just kind of an overview and introduction to dissemination implementation science. That was followed by a workshop on theories, models, and frameworks. And then most recently, we did a workshop on outcomes. And so we're just kind of working our way through the primary concepts in dissemination implementation science. And today we're going to talk about strategies. Okay. Um, so here's our learning objectives. I'm not going to read through these in detail, but hopefully when you look, how many people look up at those things and say, oh yeah, that's why I came? Raise your hand if that's only three people. What's going on here? Okay, so one of the big things in our field is there can be a lot of challenges between distinguishing concepts, and one of those concepts is a clinical intervention that is intended to improve someone's health, some sort of health outcomes, typically on the individual level, and then there's an implementation strategy, and that's usually intended to get that evidence-based intervention adopted, implemented, and sustained in typical community or clinical settings, as well as having strategies that might increase the scale or the reach of those types of interventions. Okay, so those are the two first distinctions. Another thing that we spent a good bit of time on in uh, the last two workshops was kind of this mapping idea where everything that we do in a contextual setting, whether it's a clinical setting, many folks here, or a community setting, also many folks here work in those settings. And in those contextual different areas, we can have factors related to the resources that are available that might be able to be applied to the implementation of an evidence-based intervention. And based upon those resources, we might think about the types of strategies that would fit within the specific resource level in that context. And then what we also think about is what is the outcome that we're trying to achieve? So is it that we have an evidence-based intervention already in place and we're just not getting people to it? Well, then our strategy is going to be about improving reach. We're going to try and increase the reach of the evidence-based intervention. Is it that we have an evidence-based intervention that aligns with guidelines, but it's not being used? Well, then we're going to come up with a different strategy. We're going to come up with a strategy to improve the adoption of that intervention in that specific setting. And then if we already have it up and running and we find that we're having variability in patient outcomes, and we look and see, oh, people are delivering this evidence-based intervention in different ways, then we're going to think about a strategy to improve the implementation fidelity to the intervention overall. So there's a lot of different types of strategies that we try and match to our outcomes. And when we talk about dissemination and implementation science, usually what we talk about around the science is this middle thing, these mechanisms. And so the mechanisms are the causal factors through which a strategy achieves change in an outcome. Okay. So this is hopefully for most of you, this is just, oh yeah, we talked about that last time. And for those who didn't talk about it last time, hopefully it's clear. But what we thought we'd do is we would start out with a little bit of an activity. And so we're going to do some voting just with the hands because James and I are not technologically advanced enough to use Slido. But we will, and so for the folks online, you can use the chat feature when we get to each of the questions here. So I'm going to give you a word, maybe if I can get it to move advance. There we go. Okay, so I've given you a description of a strategy, a mechanism, an outcome. What is it adoption? What is adoption? Who wants to define it for me first? Ursula.
A strategy is used or when the intervention is used?
Okay, so yes, it's when the intervention is used. So it's the uptake of an evidence-based intervention, right? The adoption. So it's like sometimes people might measure adoption as a decision, sometimes they might measure it as an action. So it might be, we decided that we're going to do this evidence-based intervention in our location, or it might be that I've decided that and I've initiated the first component of the evidence-based intervention and now I've adopted it. It's actually up and running in my area. So that's adoption. That's a great definition. So now I want people to in the chat for the online folks type in whether you think this is a strategy, mechanism, or outcome. And in the room, I'm just going to do a poll. How many people think adoption is a strategy? How many people think it's a mechanism? How many people think it's an outcome? Yes, yes. Did we get the same on the chats? Okay, fantastic. Yeah, that's good because this was supposed to be the easy one. So it did turn out like that's good. That's good inter-rater reliability on the ease of this one. Okay, so this is an outcome. Okay, so we can move on to what our next one is. Okay, so this is the word action learning collaborative. How many people are familiar with learning collaboratives? Hmm. Who wants to take a shot at what a learning collaborative might be?
I'm saying collaborative, we're thinking, okay, some collective of people together.
Yep. Some collective of people together. Good. Yeah. And Liz, if people type in the chat, you can shout that out to us. So has anyone been involved in any type of quality improvement processes? Okay. So a lot of times you might have a loose structuring around those quality improvement processes where you have people from different clinics that all are trying to improve a specific outcome. And so they work together to share their ideas on the actions they're taking to try and change and improve that outcome. And then they'll go away and they'll test. Oftentimes it includes things like PDSA cycles. So we'll say, hey, this is what we've planned. We're all going to go do it in our own clinics. We're going to come back. We're going to talk about it as we study it, and then we're going to take whatever our next action is. So that's what an action learning collaborative is. There's a lot more components to it, and we'll get a little more into it later. But now I want you to, again, people online, type in there if you think this is a strategy, a mechanism, or an outcome. Are they coming in? Not yet. Come on, folks. How about in the room? How many people think this is a strategy? Okay, we've got about 2/3 and we get up to 3/4 with the half hand raisers.
Unanimous for strategy.
Strategy's pretty unanimous. Does anyone think it's a mechanism? How about an outcome? Okay, I'm not getting any votes for those. So yes, this one is a strategy. What do you think this strategy is trying to achieve? What would be an outcome that you'd try and apply a action learning collaborative to?
Objective or a assessment, an agenda, like, a research agenda, something that a collaborative come together and.
Sure.
I have to unmute you.
Oh, I got muted.
Yeah.
No worries. Thank you. Okay, so we're thinking of when I'm saying what type of outcome, I'm thinking about kind of dissemination outcomes, which I would talk about as like reach and adoption of an evidence-based intervention. Or you might think about implementation outcomes like implementation fidelity or sustainment of that intervention. So which of those things do you think an action learning collaborative could be used for?
I mean, now that you say it, I think fidelity.
Fidelity? Okay. How many people agree fidelity? Yeah, for sure. You could use it for fidelity. How about yeah, sustainment? You could probably use it for sustainment too. You could probably use it for reach. You could probably use it for adoption. It just depends on the content and the target. So when we do talk about strategies, a lot of times we're going to talk about them on this end and kind of we're going to label it. This is what it is. But after we label it, we have to be sure why are we using a strategy? So we're not just picking a list. How many people have heard of the ERIC strategy list? Okay, the compendium of strategies. Yeah, so a lot of times people will just go and grab one of those things. They say, oh, I'm going to do this without really thinking about why they're going to do that one thing. And so really, when we think about strategy, we want to be trying to map them to the outcomes that we want to achieve. Okay, these have been really easy. So let's see how we do here. How about organizational readiness? Is this a strategy, a mechanism, or an outcome? And I'll expand on it. Organizational readiness to deliver an evidence-based intervention. What were you going to say?
Think it could be a mechanism because you would have a strategy that is working through creating institutional readiness, which then leads to an outcome of like adoption.
Okay, fantastic. So we just got a really good description in the room here that maybe this would be a mechanism because you can develop a strategy that improves organizational readiness to adopt an evidence-based intervention, right? So we could have whatever that strategy is, it improves organizational readiness. And because you improve organizational readiness, you increase the likelihood of adoption in this case. Okay, do we have another thought?
Could also be an outcome too, that,
Oh.
you've got, maybe you're working, maybe it's kind of more of a proximal type of outcome. It could be pitched that way. I think it depends on what your question is.
Okay.
To start with, and how are you getting that organization ready and kind of as a proximal outcome?
Okay. So one of the thoughts in the room here too is that potentially this could be a proximal outcome. So one of the things I would say to that, and a lot of the work that we do here is to try and help us as you design studies, write grants, and prepare things for dissemination, implementation, science, research. And so when I think about an outcome, I really keep that tightly to what are our dissemination and implementation outcomes. For those who did the outcomes workshop with Toby and I, there's two primary outcomes frameworks. There's the REAIM framework, which I use a lot. There's implementation outcomes framework, which a lot of other people use a lot. And so with those, I would say that we really want to try and keep tight on our outcomes as being things that we are measuring in terms of the uptake, so the adoption, the implementation, the fidelity of the things that we're doing, and the sustainment, really just fidelity over a long period of time. And then finally, I also think about reach at the individual level. So I want to keep us tighter on the what an outcome is. Now, does that mean that organizational readiness couldn't be an end point for a purpose of a study? Of course it could be. But really, when we think about this, we want you to consistently be thinking about the mapping idea of what's the strategy I have, what's the outcome I'm trying to change, and what's the mechanism through which that strategy works. Okay. I don't think I did a vote on this one. Did we do a vote on this one? How many people think mechanism? After that lengthy description, it seems like, okay, I'm gonna, I'm, if you're texting it on chat, excellent. Okay, so this is a mechanism. Okay, next one. Engage leadership and others for ongoing support, e.g. commitment and resource allocation. These are actual Eric strategies that I just told you. Oh my God. I'm like, oh man, okay. How many people already knew it was a strategy before I stumbled over that? Okay, good, good. So this is a strategy, right? So it's a strategy. This could be a strategy that we use to improve organizational readiness, right? So this could be a strategy that we say, oh, we really want to make sure that we have the right everything in place organizationally for the adoption and implementation of this intervention. Okay, I really blew that one. Okay, how about this one? The innovation or the evidence-based interventions relative advantage. Strategy, mechanism, or outcome.
You want to explain what relative advantage means for those who might not?
James wants me to explain relative advantage, and I'm scared I'm going to give away the answer. Yeah.
I can try it.
Okay.
It's
It's when you want to see whether there are other interventions out there that are as good, or what is the advantage of this one over the others that are existing already or are already being implemented.
Yes, very good. So we got a very nice description that didn't give away the answer in any way, but it talked about the comparison and the perceived differences in benefit. So I'm trying to avoid the word advantage there, but the perceived differences in benefit of other things that are available to try and achieve the same outcome. And so in this case, we're talking about evidence-based interventions. So I always think of this one, is it better than what we're currently doing? Is it better than other things that are pitched to us at the same time? Okay, let's go ahead and this time I actually will let people type in the chat and vote. How many people think this is a strategy? Oh, okay, we got a strategy vote in the room here. How many people think it's a mechanism? Okay, we've got tepid mechanism. How many people think it's an outcome? No votes for outcomes. How many people are just confused as heck? Okay, what do we get online? There's
A mix.
a mix. Okay, okay. There's no winner there. Okay. Well, I the way that I think of this is as a mechanism. So again, one of the things, how many people have heard the term designing for dissemination? So that was actually one of the predecessors at the National Cancer Institute was they had a whole group that focused on designing for dissemination. This was around 2000, 2002. And what they really focused on was the characteristics of an evidence-based intervention that made it better than what people were already doing. So it made you think about what's the landscape of services that would be competing with the type of intervention I have. And so I design for dissemination, which can include things like looking at the structure, the content, the flow, where it fits within a specific organizational workflow. All of those things can lead to a perception of a relative advantage of this intervention over others. And because of that, you again would get higher adoption, right? Because I look at it, I perceive it as better. Because I perceive it as better, I begin to use it. You could also think of relative advantage. I don't think we said it depends on who's thinking about it, right? We can also think about it relative advantage for the participants who could benefit. So if we're thinking about reach, I do weight control. How many different interventions are there out there for weight control? There are so many that really thinking about what is the landscape and how do we design what we're doing that is better than, right? And so that's the mechanism. The mechanism is we get perceptions of relative advantage from the audience that's intended to uptake the intervention, and then that leads to the adoption. Yes.
Yeah, so my first instinct when I read that was, could you also think of it something that you're looking at before you can try and perceive, I don't know, how the intervention is perceived before. I get what you're saying of how then you would influence that potentially through a strategy, but it might be involved.
I won't do that again.
Okay, no problem. So the question in the room was, could it also be a determinant? And so I would say, again, it depends on how you're using the specific variable. And in fact, I've moved away from using the term determinants because I feel like it's a little bit confusing because relative advantage in if you're putting a determinants list together, you would put that down on that list. But a determinant isn't, there's no conceptualization about how that's responsive to strategies and then how changes in that lead to an outcome. And so I prefer to think of them as mechanisms, but I would tell you if you wrote, oh, in my determinants model, I have relative advantage, compatibility, complexity, all of these things that I think are mechanisms could also be labeled as determinants. Yeah. Yeah. Okay, maintenance. Who wants to define maintenance? Poor Ursula. I look right over and she's making eye contact. Maintenance. Who wants to? I won't make you do it.
I do it. I volunteer. for
Okay,
it.
excellent.
I would think that once an intervention is adopted, to keep using it.
Yes. Okay. So, yep, just keep the intervention in use, keep it delivered, right? So, I sometimes think James and I were talking a little bit earlier in the day about, kind of outcomes for, or earlier in the week about outcomes for dissemination implementation science. And, one of the things that I talk about often is that really when we think about the REAIM framework, sometimes people say it's 5 dimensions, sometimes people will say it's 6 dimensions because maintenance has an individual level maintenance and an organizational level maintenance. But the way that I really think about it is 3 unique constructs that are measured at different points in time. And so for me, maintenance is simply, adoption is the initiation of implementation, the initial delivery of an intervention is implementation, and then sustained delivery of that intervention is maintenance. So it's the same action. It's just labeled differently because of the different temporalities in it. So yes. So now that I've probably just given the answer, how many people think this is an outcome? Yes. Okay. It looks like, did we get some people already chatting it in there? Fantastic. Okay. All right. How many more of these do we got? Initially I thought, oh, I don't know if this is enough. And I'm like, oh, okay. So we got maintenance there. Okay. Our next one. This is a mouthful. Use audit and feedback or some type of automated periodic data reporting to monitor and encourage uptake, implementation, and sustainability. Is the term audit and feedback clear to everybody? Okay. Okay, I'm not going to belabor this one. What do people vote on it? On Asai, what do you think it is? Oh, potentially. I'm going to keep going around the room. I love when people say, oh my God, he just made eye contact. Okay, so we have one vote for mechanism. What are we getting online? Strategy. Okay. This is another one of those that I was just going to say, oh, this comes exactly from the ERIC. All of the strategy ones that I put up here, we just pulled directly from the ERIC compendium. But yeah, so this is a strategy. And in fact, there's a little bit of a hint in there too. I can see why you thought maybe mechanism on Asai, because you've got oops, we just lost the screen here. Oh, there it is. It's back again. Okay. It kind of has that hint because encourage uptake, implementation, and sustainability. Well, oh, that could be a strategy. It could also be a mechanism if things that encourage that. So, yes.
There a good way to kind of conceptually think about strategy versus mechanism? I'm the
course, and so I'm trying to catch up a little and get some contextual clues, but I'm curious, to me, like, mechanism seems like a little more specific and kind of within the strategy, but I'm curious if there's a good way to just conceptually think about.
Yeah, I think that probably, and I'm going to channel James because I've heard him say this before, where I think mechanisms come directly from your theory of change, right? So if you have a theory as to why a specific evidence-based intervention would ultimately be adopted, implemented, or sustained. Within that theory of change, you're proposing mechanisms. Strategies typically are things that are trying to take action on your theory of change, right? So if you use a theory like PRISM, which is one of our D&I theories, or the Consolidated Framework for Implementation Research, it doesn't tell you very much about strategies. It tells you about concepts that either you should be trying to match your strategy to, or concepts that could be mechanisms of change. And so I always go back to the theory. Your mechanisms are derived from your theory, and strategies are, in essence, the action that you take to make that change.
I would
James.
just say, I think that's totally right, and maybe a really quick way to think about it. I don't want to spoil the activity, but the learning objective is to get this down, right? So a strategy is something you do. A mechanism is how it works, and the outcome is what's changed. So a strategy is like an implementation intervention. So something that we're doing specifically, an action, a verb. So look for the action or the verb on the strategy. Think about it that way, maybe.
Good. And if you guys couldn't hear online, James gave a really good distinction for the strategy. It's the thing that you do. So I really like that idea. Okay. So with this one, we already went through that. We have got the strategy. Where's my mouse? There we go. Okay. This is the last one. Acceptability. Okay. Who wants to define acceptability for me? Acceptability of an evidence-based intervention.
People are willing to say that they think was done for them.
Yeah. Okay. So it could be defined as people willing to use it. It's something that fits for them, that they feel like, yeah, this is an acceptable thing for me to do, which it's terrible to use the same word in the description, but the lay term in this really does align well with this construct. Okay. So the acceptability of the evidence-based intervention. How many people think this is a strategy? Good. It's not something you do. Strong effort, James. How many people think it's a mechanism? How many people think it's an outcome? Let's get it online. What do we get online?
We had mostly outcome, but also mechanism and outcome.
Okay, mechanism and I like, so people wrote in mechanism and outcome as a response. Oh, that's just cheating. That's okay. So what would you guys think if I put that up there? Who would argue with me? Raise your hand if you're okay. Let's hear it. Let's hear it.
Oh,
We're-
I mean, I think, well, whenever I think of acceptability, I think about how well the uptake happens. And so I think of it more as an outcome than a mechanism of, yeah, the result of uptake instead of like how it's working in the process.
Okay, so Kimberly's saying that she feels like it's more of the result of the uptake, which is why she would consider it to be an outcome. This is where I kind of land on it. If you use Proctor's implementation outcomes framework, acceptability is labeled as an outcome. If you use the REAIM framework, it's not listed as an outcome. If you use the expanded REAIM framework that we published about 4 years ago, it's defined explicitly as a mechanism. And the reason is that you can do things, you can create strategies to improve the acceptability of an evidence-based intervention, which will lead to adoption. Okay. If you assess that acceptability during implementation, it will lead to, if it's high acceptability, you can design things to ensure that acceptability is sustained. It should lead to maintenance. And so we really think of it as a target of a strategy to lead to an outcome that can be defined as some sort of direct implementation. So I don't know if that's helpful to folks. I think that if you're doing pilot work and a lot of people do acceptability and feasibility trials, and this will definitely be a primary outcome of a study. But when I think about the things that we do, I always think if I went into one of our community partners and said, our endpoint for our project is going to be that this is acceptable to you guys. How do you like that? They would say, well, what does that mean? Does it mean like it'll be adopted? Well, it might be adopted, but it'll be acceptable. And so I feel like that's where I kind of think about the just the feel of it. So this is one of those that we purposely included here because I think that you can think of it in a couple of different ways. And as long as you're clear about how you're using this particular type of construct, I think you're okay.
So in that case, also called feasibility as a mechanism?
I would, correct. Yeah. And appropriateness. Yeah, all three of those. And then we talk about temporal assessment of them and then the audience as to what outcome it's going to influence. So acceptability, feasibility, and appropriateness from the evidence-based intervention beneficiary perspective is going to lead to reach and likely sustained engagement. Okay. So there we go. These are the two primary outcome frameworks that folks use in dissemination implementation science. There's not a right or wrong one to use. There is probably a best one for your given project. And so if you are in preliminary work around introducing an evidence-based intervention in a novel context, then probably like I would think maybe things like Proctor's framework would be better, where you can use things like acceptability, feasibility, and appropriateness as outcomes. If you're using a hybrid design, REAIM works a lot better. Okay. Other questions, comments? Maybe I'll pause for a second. Okay, so this is a really nice slide that James put together, and it's intended to help you think about the type of strategies that you're going to try and use or how you might label the work that you're doing. And I really like the kind of yes, no, I always like if then types of logic. And so when you're looking at your change method, which we would also call your strategy, you can ask a few questions. So does your strategy have a direct impact on the recipients? And so could be the participant, the patient or client who would have the health outcome. I oftentimes just call this the beneficiary of the evidence-based intervention. So if you say yes, then what you're really looking at is trying to design an evidence-based intervention to improve the effectiveness outcome, right? Because that's what you're trying to change. You're trying to change health in participants. But if that's not your direct goal, because it is the goal for almost all dissemination implementation science, but if it's not your direct goal, then the next question you'd ask yourself is, does the change method target or impact the initial uptake and use of the clinical preventive health intervention? I'm just going to call that evidence-based intervention as we go forward here. Then we would say, okay, if you say yes, we really want to try and improve the adoption of this particular program at a setting level, then you're using a dissemination or implementation strategy. One thing we wanted to point out today is that the term implementation strategy is kind of loose. And we also, sometimes people will talk about dissemination strategies. In the work that I do, I talk about reach and adoption and any strategies you're doing to try and achieve those outcomes as dissemination strategies. That is not universally used language. I'd say it's common, but it's not everybody. So sometimes people will call, even if you're targeting adoption, an implementation strategy. Yeah.
Sorry, question on mine.
Yes.
Clarification, is adoption the adoption of the intervention by participant or the adoption of a program by an institution?
Yeah, I think I would touch up our question a little bit just to say that does the change method target or impact the initial staff setting organizational uptake and use of the evidence-based intervention. So I think, yeah, we might just touch that up the next time that we do it, just so it's really clear, which is then why it's adoption, right? Because adoption is operationalized at the organizational staff setting level. Okay, so let's say that it doesn't focus on the initial adoption. It says, does your strategy target the impact of the delivery system or the implementers to deliver the intervention? So is it focused on helping people better deliver the intervention? And if the answer to that is yes, then it's truly an implementation strategy, right? And we're looking often, and we use like implementation strategy to change implementation. We know there's a lot of different components of implementation, right? You could just look at adherence to protocol, which would be a good fidelity measure. You could look at something like dose received as, or dose delivered, I guess is a better way to think about that. So there's a lot of different ways that we can operationalize implementation. But if your change method is targeted at any of those types of things, it's an implementation strategy. Well, let's say that it's not targeted at the delivery and the delivery quality. So we go to our next question and we say, does the change method target the delivery system to impact the sustainment of implementing the evidence-based intervention? And so if yes, that's a pretty straightforward one. You're looking at maintenance of the evidence-based intervention. If no, does the change method seek to improve the number, proportion, or representativeness of individuals participating in the evidence-based intervention? Yes, then it's a dissemination strategy in my perspective, and it's focused on reach. One of the other things that we won't dive too deep into today is how many people have heard of adjunctive strategies? So not very many people. This is an area that really does, it includes, but goes beyond strategies that focus on reach and engagement with an evidence-based intervention. And so they don't often fall cleanly in one of these 5 different areas that we've provided. So James will talk a little bit more about that as we move forward, but it's another type that you'll hear. Okay. Yes.
The yes, no about this. Is it possible that one change method might impact multiple of these things? Or is it more of like, I'm just thinking about like my particular project and obviously like you have more than one outcome in projects all the time, but is it that like there's different change methods necessarily, or is it possible for it to do more than one and maybe it could be yes and rather than like no?
Yeah, for sure. And so we've really put this as very simple. There's always a discrete answer to these things. I'll use, we in the Prevention Research Center core research project, we're using an intervention called Building Healthy Families, which is a family focused weight management program for rural areas. And with a CDC grant that Jenny Hill and Kate Heelan led, we designed a program package that included everything necessary for a rural community to receive all the training, all the participant facing materials, everything they would need, a data portal to track results, all that kind of stuff, everything embedded in one package. And all they would have to do is press start here, and then they could develop the capacity to deliver the program. And so that is a strategy, right? And so what's the goal of that strategy? Who would say, what do you think our primary goal of packaging that all up like that is? It speaks almost directly to your question. There's kind of a primary goal. One is that we know that packaged programs improve the relative advantage of the program and reduce its complexity for implementation. And we know those are mechanisms of adoption. And so we create that to make it a much more adoptable program for these rural communities. But within there, it has all the training embedded, fidelity check sheets, things for them to review as a team. It encourages a lot of interaction back and forth. So what does that influence? Maybe adoption, but much more implementation fidelity, right? And so this one strategy that we put together And it works through a different mechanism too, right? It's not about relative advantage and complexity. When we do the training, it actually works through competence of the people delivering the intervention, increasing the competence, improves the implementation fidelity, and that's our outcome. And so I think, I don't know if that was clear, but the idea is that we can have strategies, and oftentimes the strategies that we create have multiple outcomes that they're going to influence. And one of the things when we talk later on, boy, I'm giving James a lot of stuff to talk about, but when we talk later on about kind of the lists, when we go through and we start to try and track our implementation strategies over time, identifying what our primary outcome is from that. And then we can also think about secondary ones. And James would like to weigh in.
I'm just going to add one thing. The main takeaway of this slide was to really get you thinking differently about what is an implementation strategy versus an evidence-based intervention. So these are all examples of the different implementation outcomes your strategy could target. So yes, and your strategy, as Paul said, could target multiple outcomes, but really understanding the difference that in implementation research, we're focused on testing implementation strategies, and we assume that the intervention is evidence-based. So we're not interested in establishing that it's effective. We assume that it is, and we're trying to get it in use. So that's kind of the main takeaway. I didn't want that to get lost.
Yeah. Yeah. Excellent. And I would say the second main takeaway is that there's a lot of different strategies that you could do. And walking through this and being clear on what your strategy is really important, right? So that you're understanding where you're going. And the nice thing about this is that it can definitely help us distinguish between strategies and interventions, but it also helps to look on the I guess for you guys the left-hand side. We tried to put the outcomes, and to me that is also a critical message of this type of slide, is you're focused on what is the outcome you're trying to change, and that's really how you start to build around what type of strategy you're going to use. And so the purpose of this slide obviously is to tell you, what is an evidence-based intervention? How many people feel like they can just go out and tell somebody what an evidence-based intervention is? How many people have heard people say, we have this evidence-based intervention, and you're like, I don't know if that's an evidence-based intervention. We've heard that, right? And so, one of the things that we talked about in can't remember which one of the workshops earlier, but that, there's different levels of evidence-based too. When we think about evidence-based interventions, we're really thinking about something that has been research tested. And as James just mentioned, it documented the efficacy or effectiveness of that intervention to improve health outcomes for a beneficiary population. Okay, so that's what we're looking for. We have a whole bunch of different types of evidence-based interventions. I really like the 7 Ps that Brown put together, and this is, 10 years ago or 8 years ago. Feels like they just published that around the corner ago. But it can be a whole bunch of different things. So it can be a pill, a program, a practice, a principle, a product, a policy, or it can be procedures. And this you can tell this is one of James' slides too, because it has the HIV focus to it. But it's a really good health outcome that helps us understand there's a whole bunch of different interventions that can influence that type of health outcome. And to be evidence-based, these things they have to be research tested. Okay. Any questions on this one? Yes.
This might be not where we want to go today, which is fine, so you can table this, but I think where I struggle is that I feel like you often can't tell if the thing is effective because of the intervention itself or because of the implementation. And so those are studied separately. Like, how do you disentangle those outcomes, especially when you're scaling to a new population or a new setting?
Yeah. So the question was, how do you tell if the effectiveness of a given intervention was because of the intervention itself or because of the implementation? And, I think that's a really good question. I don't know that we're going to dig super deep into it, but when I think about that kind of thing, how many people have heard of type 3 error? Like, I have type 1 error, type 2 error, type 3 error. Type 3 error is that you have an evidence-based intervention that is not implemented with fidelity, and because it's not implemented with fidelity, it says it's not effective. Okay, and so when I think about the things that you've just mentioned, the clearly, and we are gonna, do we talk about the voltage drop and stuff today? No, we don't do that. Um, Maybe I'll table this so I don't start going down too far a pathway on it. But just to say that I think that when we do monitor and look, especially in hybrid type trials, like I think back to the Building Healthy Families program and in the CDC pilot project, we showed that if you just gave folks that packaged program, or you gave them that package program with an action learning collaborative, that all communities effectively saw decreases in child BMI status. So they were both were effective. But in the communities that had the action learning collaborative, the magnitude of effect was doubled. And so that doubling, we kind of feel like that's the part that's the implementation. And the other part is mostly about the intervention, right? But it's really hard to tease those two things apart, right? Because we know that effectiveness in some, I have one study where we proposed implementation, which is really confusing. We proposed implementation as a mechanism of effectiveness, right? Your implementation quality is it directly leads to the improvements in effectiveness. So I think it's all around your question there. And I think that it's really hard to tease apart that.
So would it be fair to say that it's possible that evidence-based intervention may include not only what, but is how it is used as well. So for example, you provide a particular music therapy, it needs to specify not only how it is, not only intervention, but also how frequency it is given, by whom.
Yeah.
So those kind of stuff. So it's more like a mixing, not only intervention, which is what, but
Yeah.
including how it is delivered.
Absolutely. Absolutely. And when you develop that stuff, and that's where a lot of times, especially when we have multi-leveled interventions, that our implementation strategies often can be embedded within the intervention itself. So if you're saying we're going to do this music therapy and it needs to be delivered by someone with this level of expertise or this specific expertise, and it needs to be delivered with this level of frequency, those are still components of the intervention. But you can start to build guidance around those things to ensure that the intervention is delivered in the way that it was intended to be delivered.
Can I ask you a little bit further? Even though the interventions that we specify include both interventions and how it is implemented, I would say that when it comes to reality, when you use it, there still need to have implementation strategy somehow to ensure that it will reach the end goal. Because
Yes.
I'm just thinking out loud. I don't know this stuff. Does
Yeah.
it make sense?
Yeah, no, it absolutely makes sense. And I would say that a lot of times we do have, again, kind of embedded within an intervention itself, there's strategies to improve. Like, so if we talked a little bit about the adjunctive ones, and so that's a really good example where a lot of times we do things as we're developing interventions for effectiveness that are intended to ensure that participants continue to come. And so is that part of the content of the intervention? It might not be. It might be that we say, hey, the instructor, we expect you to send out a text message, 2 days before the sessions. And with those text messages, try and be personable and, remind people of where they're going to be. And so that is a part of the intervention. Well, yeah, it's part of the intervention, but it's often a part of the intervention that's not typically described. And so I do completely agree with that. And then I also agree that we need additional strategies to ensure that we're getting optimal reach, adoption, implementation, and maintenance of those interventions.
Can I make one last comment? I'm sorry for asking too much. I just feel like I come from the evidence synthesis, like a Cochrane
Yes.
approach, trying to look at interventions. And I found that majority of interventions that they describe have not incorporated the way it should be implemented yet.
Correct.
So obviously there are a big gap in terms of evidence intervention is not sufficient to lead to good outcomes unless the studies, even clinical trials or effectiveness studies, start to be incorporating part of implementation strategies as part of evidence-based
Yeah.
or some sort of
Yeah.
component interventions. Otherwise, the work that people say that it works, if we have some big evidence practice gap.
Yes. Yeah. So the point that it just dawned on me that you were making is that when we do design evidence-based intervention or interventions and we're working to demonstrate that they have evidence that underlie them, that the concurrent development of, whether it's manualized or not, but concurrent development of how the implementation occurred is critical for people to be able to replicate. And I think that's a big part of it too. Like, we do how many people here have developed individual level interventions to improve health? Okay. A good number of folks. And how many folks, when you've done that, have you taken your protocol and put it into a document so that somebody later could do it? Raise your hand. How many haven't? Uh, I would say I probably have about half and half, where you're just doing it and you're doing it and you're testing it. And a lot of times, part of it is about science, where we're developing evidence-based interventions to hopefully have a public health impact. Um, but the development of evidence-based interventions is also about moving scientific principles and theories forward. And so a lot of times when people that are doing this type of work, they're more interested in the mechanistic relationships that they're taking action to change, and they're testing to see if those things are real, if those relationships are real. And so I do sometimes give folks a bit of a benefit when they're doing efficacy research, that they're not packaging everything up for somebody else to do, because what they're really interested in is, what are the principles that I'm testing, and am I advancing kind of theoretical concepts that would move forward? So I'm going to keep us going. Well, okay. So the next thing we wanted to do is just give a little bit of we're not going to run through all of the 73 ERIC taxonomy. But when we talk about implementation strategies, we really liked how, we have some of these folks, Byron Powell, I think, was the one who first kind of put together, these are the general areas of strategies. And so you can see we can do things where we engage consumers, which is a very broad category, right? But I think would think about user-centered design types of processes and that kind of thing. We can use evaluative and iterative strategies, and that's a really good word for things like audit and feedback, right? We do, I know there's been a number of studies recently that have come out that kind of track re-aim outcomes over time with the setting that's doing implementation, and then change strategies based on which of those dimensions a given clinic or partner is struggling with. Changing infrastructure is one that I think a lot of times we don't really focus a lot on. Right now, we're doing, as part of the RC2 project for the CTSI, integrating rapid genome sequencing into the NICU. And one of the things that we developed was, I did not develop it, I just helped on the D&I stuff, but we developed a PhenoPlus tool that allowed for that rapid genome sequencing to be communicated for potential needs of therapy in an automated way within the electronic health record. So that's really something that's changing the infrastructure to try and improve the uptake of rapid genome sequencing, which in this case was our evidence-based approach. Adaptation and tailoring to context, that one I think is pretty clear. Developing, we're kind of shifting towards interest holder instead of stakeholder as a word, but developing interest holder relationships, which, that's a lot of the things where we think about community-based participatory research types of strategies could fall in here that are not always dissemination implementation science strategies. Using financial incentives, supporting clinicians. So that's things that try and make sure that people's workflows aren't overburdening, providing interactive assistance. PhenoPlus could fall under there too. And then training and educating stakeholders. And James is going to give a really nice description of how much these different types of things are being used. Okay, so is this all pretty clear to everybody? Distinction, now we feel, if I said relative advantage, you'd say, hey, that's a mechanism. If I said acceptability, you'd say, hey, we need to argue. Okay, good. So I wanted to just give one last link back to one of our previous workshops, and it's the idea of the context strategy mechanism and outcome mapping. And so when we think about the implementation strategies, we really want to start with thinking what's the strategy's intended outcome. And usually, one thing I talk about a lot is you can't really do dissemination and implementation science outside of partnerships. You always have a partner. There's always a setting that you're working with. And the outcome is typically the priority of the setting. Like, where is the hot spot? What's going on in that setting? So usually the strategy's intended outcome is kind of the first thing that we identify is what's the need? What's the need in that particular context? And so for us, I'm going to give you one example here. We wanted to improve adoption of building healthy families in rural communities. Okay, so the next thing is, how does this strategy fit the context? So if we want to change adoption, so we really want to improve adoption because we just don't have very many family healthy weight programs in rural areas. What type of strategy would we want to use that fits within the context? Well, we need to understand what the context is here. And so one of the things that has been true for a lot of years is that community health implementation plans in rural areas have identified childhood obesity as a priority, right? So that tells us about the context. So we're trying to get an evidence-based intervention adopted in an area where it matches with priority, right? And so we don't need to, in that case, we don't necessarily need to be trying to change the priorities in communities. We don't necessarily need to be changing the motivation of a community. We need a strategy that really just kind of lets folks know that there's opportunities to address that priority. And so for this one, we selected a fund and contract strategy. And with that, basically what that is we sent out a call for applications for communities that would like support to initiate a childhood obesity program in their area. And so that's why we picked that strategy. And then the next thing is we want to understand why the strategy will work to achieve the outcome. So we want to think through exactly how that would happen. And for this one, and we used the IPARIS framework, so you can see some of the external and inner contextual factors labeled in there. But we felt like the fund and contact strategy, the way that we set it up to ensure that there was community collaboration in the process of submitting the application, that we would increase collective efficacy and cross-system collaboration in rural communities, and that would increase the uptake of building healthy families. So this is, when you're thinking through your strategies, I always like to come back to, and this is so simplistic, right? Like, this is very reductionistic of what we're doing, but it kind of hits those three key questions. What's the outcome of your strategy? How well does it fit within the context? And then how will it change? What's the mechanism by which it will change the outcome? And so kind of thinking through that, I'm going to give you a few examples here. So these are based on REAIM. So here's a definition of a strategy for REACH, a strategy focused on individual level dissemination of an evidence-based intervention intended to improve REACH. So this one, we're going to label it as a direct text outreach. And so one of the things that we're doing with a current project, our Prevention Research Center project, is that we are identifying families that could benefit from building healthy families. And then we're doing direct text outreach and different randomized patterns of the frequency of text messaging and with or without active follow-up. So, but that whole strategy is built around, and our primary outcome is built around improving reach, just improving reach of the intervention. And so you get a sense of the specification here, and we're going to go a little bit. How many people have heard just even the term specifying your implementation strategy? Raise your hand if you have. Oh, great. We're going to introduce something relatively new. So specification, again, we're going to go through in a little more detail, and we'll have an activity after the break on that. But does anyone have a question about this? So this is a pretty clear strategy, yes? We use direct text message outreach to improve the reach of a program. It's not intended to change physical activity behavior of the families. It's not intended to improve healthy eating. It's not intended to change the weight. It's intended to get families into the intervention that will lead to those health benefits. Okay. Oh, this time it really lost it. Okay. So then I'm going to go on to adoption. I've already talked through this one. So the fund and contract, so I won't go through that again. But here's just kind of a way that we want to think through it. Like it's what defining what you're doing. So this is a strategy focused on improving staff, organization, or setting level adoption. We have, and we say who does it. The advisory board distributed our RFA. And then we have community call for applications reviewed by our community advisory board and investigators. And then we create a memorandum of understanding with the communities. Those are the actions. That's what we do as part of the strategy. And then from a mechanism standpoint, we think that this improves the compatibility with community priorities, and that results in improved adoption. Okay, so again, I think a lot of this stuff for me is us just being really clear in our communication in what we're doing and how we're moving forward on these strategies. Okay, so then this is one I talked about a little bit earlier as well. Here's our packaging for building healthy families. So the definition here is a strategy focused on improving the implementation of an evidence-based intervention, online training with knowledge checks. And so you can see here, part of this, who's delivering it? Well, it's online, so it's technologically available to folks. What are the actions? It has specific training for physical activity, nutrition, behavior change, and program coordination. It's intended to improve community capacity mechanism for high quality implementation. That's the outcome. Okay. And so with this, one of the interesting things that I always feel like I don't remember exactly how we came up with the idea, but we have knowledge checks as part of this. And I think, one of the things you worry a little bit about is when you just gives a community an online resource to deliver a program, especially something like childhood obesity, that you kind of want to make sure that people understand how to be people first, that you want to make sure they understand this is not about dieting. This is not about, there's a lot of key stuff that you want people to know. And so in this particular program, we built in knowledge checks that they had to use to unlock the information necessary and the sessions to be able to deliver for families. So it has a little bit of a check in ensuring that one mechanism that we know is insufficient but necessary for high quality implementation. We know that knowledge will be achieved because it's built within the strategy to assess that mechanism. Okay. And then the last one, again, your question was so great about if a strategy hits multiple outcomes, because within that online package, we have a data portal that every week the families track their goals and their weight status. And that can be used by the folks that deliver the program, both for the families. They can provide families with their weekly reports and show how they're improving and progressing over time. But they can take de-identified reports that are built into the system that can be kicked out for them to take to their interest holders who may be providing budget and support for the program so they can demonstrate their impact within the community itself. And the whole idea about this type of data portal is that it's intended to lead to long-term sustainability of the program because you demonstrate your relative advantage. Okay. There we go. Although I put the observability of program impact as the mechanism there, which it also is a mechanism. Okay, the last thing that I wanted to do here is when you guys start thinking about strategy, and I think this is a little bit towards your question too, that a lot of times there's what our primary outcome is and what our study's designed to do. And then there's a whole bunch of other strategies that we're doing as well. And one of the things that we encourage folks to do is to be as descriptive as you can about the work that you do. And so I'm just going to kind of build out for you guys our we already talked through with our Building Healthy Families program, the fund and contract approach. That is not primary outcome. It's not a secondary outcome. It is something that we just descriptively reported on. This is a way that we identified communities that would participate in the dissemination implementation study. And then we have REACH, which is our increase in participation of families that could boast most, stumbling over that. Our primary outcome is just overall increasing participation of rural families in building healthy families, but we also were intended to engage lower income families. So that was a population that we also wanted to track and follow. So for this one, again, I'm not going to go through the context, but you guys can look and see what the context is here. In this particular one, we adapt and tailored to the context. And so our initial package that we put together for building healthy families did not have a recruitment module. But we found that it was a persistent issue in rural areas was identifying and engaging families to benefit. And so we put that module into the intervention. And the intent was that it would improve family awareness of the programs and increase family engagement, which would lead to reach. Then we have our implementation. And so again, I'll give you your context. We have some training and evaluation components and infrastructure change with our online portal. I don't know, I guess maybe I'm not going to show the other one. This is part of our primary outcome line. But again, you can see that there's different mechanisms that work through to improve implementation fidelity. And then finally, I just kind of walk through and show. And so overall, if you're somebody that's using the REAIM framework as one of your models as you're developing a study, you want to make sure that you can describe through everything that you're doing to either facilitate or enhance that particular outcome. And that doesn't mean that all of these things are manipulated, right? Like there's usually only one of these lines that gets manipulated. Okay, I'm going to stop and see if there's questions. Are there questions online, questions in person? I feel like I've gotten to the glazed eye portion of the workshop. All right. Well, then we are going to do a 15-minute break. So we will join back in here at 10:25. Does that sound for folks? Thanks.
All right. So before I get started, I just wanted to introduce myself. My name is James Merle. I'm a assistant professor here in this building and down in the dungeon in the basement. We like to call it the dungeon. Population health sciences. So I've been here. I did my postdoc work here, trained with J.D. Smith, and learned so much from Paul. Thanks to Paul for our fun activities this morning, and I'll kind of be carrying us most of the rest of the way. So we are going to do a activity. I wanted to introduce a few concepts, and then we're going to do some small group work to kind of just carry this home. So I'm actually going to skip over this. So in implementation strategies, it's really important that we don't just kind of give a name to our strategy and then we run out and test it. We really have to specify some core elements of that strategy. This is really important. This is a huge kind of a problem area in implementation science. As I was talking to someone earlier, the specification of not only our evidence-based interventions, but our implementation strategies are really underspecified in the literature. And this has a ton of implications for problems that really, if we don't know like exactly who's delivering something at what dose, what's the mechanism it's supposed to work, and all these things, we cannot replicate this. We don't have any transparency in implementation science, and it just leads to a lot of problems. And we're not really taken seriously as a science if we can't actually understand exactly through what mechanism and our kind of chain of action that these things are happening. So this is really important. This comes from Enola Proctor published a reporting guideline of implementation strategies back in 2013. And these are kind of the core elements you need to specify for each of your strategies. This also becomes really important when you're doing work with a implementation partner, because you might talk with them to try to select an implementation strategy. But if you don't talk about who's going to do it, what does it actually take to do it,
they're not going to really have a good idea of, is this a feasible thing that, I'm the person who has to go and do this strategy to make sure that the thing we want to get implemented is going to get implemented. So this is really important. So the first thing that you need to do if you're trying to figure out what implementation strategy am I using, or I've selected one, now what? It's really good to give it a name. But then you need to identify who's the actor or who delivers or enacts the strategy, the action, and these are our verb statements of what is actually done to deliver or enact the strategy. The action target, who's your audience, who are you delivering it to, or it might be delivered onto a system. Maybe it's a workflow integration. So you would be targeting the inner setting or a process within there to make it more efficient. So it's not only who's the target of the strategy, but through what mechanism it seeks to achieve its effect. The temporality, this can be specifically a date. When does the strategy start and stop? For like, say, if you had training and you trained them at pre-implementation, 2 sessions, and you wanted to capture those dates, that can sometimes be meaningful, or just pre-implementation, during active implementation, or during the sustainment or maintenance phase. And then at what dose? Well, how frequent is the strategy delivered, or how long does it take? You can think about training. Maybe it's 2 sessions for 90 minutes each. These are really important to know exactly if you're trying to transport that into another system, how long does it take to actually get people trained to deliver this effectively? And then justification. So why was the strategy selected? This can be anything from identifying contextual factors or barriers that you're trying to overcome or to seek to achieve a certain outcome. Okay, so this is an example. This next thing we're going to do is an activity. It comes from a study that Paul conducted, I believe actually Jenny led. And so what I'd like you to do is there's some text up on the screen. This is just some general description of the strategy. And I want you to get into maybe a group of 4 or whatever makes sense. And we really want you to break out your laptop and be the note taker. And we want you to take this information and specify it with these 1, 2, 3, 4, 5, 6, 7, 6 elements. So we're going to take about 10 minutes to do this. And any questions before you break out into that? All right. And then folks online, I believe Toby is going to guide you through how to do it online. And we'll just ask you all to work as a group to do the same thing. So 5-10 minutes, go ahead. All right, online folks, we're going to come back together. Okay, which group would like to volunteer? What was something that was easy to identify from this excerpt?
Then there was the nightfall.
Any volunteers? What was easy to identify? What was the first thing your group went to?
Well, I'll say I think the actor was a little hard to identify, but I think we quickly identified the action target being the community implementation team.
Right on. Yeah. Did anyone else have that as the action target? And then the second part of action target is through what function or mechanism it seeks to achieve its effect. What did someone want to volunteer to say? What did you put for that? Or was that something you could not identify from the text? Yeah.
Like the strategy here was pretty clear, but the mechanism we struggled with that. Like the how. There's a lot of action statements there, but unless we missed it, we couldn't really figure out and we found the outcomes, but struggled with the mechanism.
Gotcha. Yeah. So this one maybe isn't totally specified, right? We see this a lot in the literature where you might see something like this and you try to pull out what is this stuff. So that one might be a little underspecified, more so we can understand who it's being delivered to or who's engaging in the strategy, but it's not clear how this is actually going to get us to our outcomes. All right. Let's go. So we start with the action target. Let's go back to the actor. Who do we say was the actor? And maybe if our online group wants to share too, I don't want to exclude you all, but did you guys get the same thing for action target? I'll go back to that.
Yeah. I'm asking if anyone wants to speak, so then you could.
Oh, feel free to
Yeah.
come off mute and speak if you'd like, or Toby can be our mouthpiece.
Yeah, for actors, we had community implementation teams and the research team as two of them.
Great. Did everybody get that for actor? Okay, let's move to action. What did you all put for the action? I'll ask another group who hasn't shared yet. Our back group, what did you guys put for the action? Yeah, so there were I have my back group say there were multiple actions that went into this strategy. And this actually touches on a concept that we didn't really talk about, where strategies can sometimes be these bundled or blended things that have multiple actions, sometimes even multiple actors within them. And so this might be a strategy that we want to break up a little bit and identify there's some nested actions within this learning collaborative, right? So can you say for me again the three? So learning, peer sharing, goal setting, and planning. So ideally, we would want to specify and almost create like a little like 4x4 of we'd want to know all of the different components of this for each of those actions. Not necessarily into as much detail, but as much detail as you could provide around those things, because maybe if you wanted to implement this somewhere else, but you didn't want to do all those elements, it'd be hard to know what got you to your outcome. If we had all these actions, but you left one out, how would you know that you got that got you to the outcome you're trying to get to? So really good. All right, let's go to temporality. Who wants to share what they put for temporality?
It seemed to make sense that this is really happening during active implementation. At least that's
Okay.
what we were able to extract out. They're doing it in the thick of it.
Yep, so we had an answer for active implementation, right? Any different? Go ahead.
That's the thing about, we're reflecting on implementation that have been, it says review of previous implementations. And so we were like taking that as possibly this the maintenance, like it's already kind of iterative in there. That was our struggle.
Yeah, great point. This one to me seems like it carries through all three phases. It's something that's happening. We didn't get into dose yet, but that's the first sentence, right? It's happening 90 minutes for quarterly learning sessions. And maybe Paul, if you wanted to share, is that true? When was this actually used?
Yeah, I think that, first of all, I completely agree that we didn't do a great job specifying the temporality with what we put up here. And in fact, I just pulled this description, this stuff directly from the grant. So this is how we describe it in the grant. But what we didn't give you was we also had a specification table in the grant that gave some of the missing information here. But where I think the cue is at the bottom of the first part, where it says problem solving to improve reach, adoption, implementation, and sustainability. And so if we're thinking about adoption of the program, it has to be before implementation. And so that would have been my only tip, but you would definitely have had to make inferences. It's not explicit there.
Yeah, great.
And it's a 2 years. And so it would start right from before the initial adoption, go through what we considered sustainability, which would be a third cohort of families.
Gotcha. All right. And then the last one is justification. Someone either online or in the room want to share what they put for the justification?
I put down the part where it says it's grounded in the Edmonds consultee-centered training principles. It's part of the justification.
I think it was kind of part of the justification, but we kind of tied it to that excerpt right there where it says it was grounded in Edmonds consultee-centered training principles.
Okay, we had someone in the room say it was grounded in Edmonds consultee-centered training principles as the justification. Good. Yep, we could kind of see that as maybe this is something that's worked before, so we're going to try to use this. It's already established. We don't want to develop our entire new method, but we think that this is going to work, and that's why we selected this method. I think that helps justify. Yep.
Justification, why was this strategy selected? Like, I was reminded of the previous slide where there was like context, and I was like hoping to kind of like see more like what is the context of like in addition to in addition to what's already been kind of written. But I'm just thinking of this now. But I'm curious if that might be part of the justification, or if that's frequently or commonly used as, or if that's what you're getting at with justification.
Yeah, we had a comment about whether or not the context is important to establish justification, and that maybe that was missing a little bit. I completely agree that we'll often want to justify something. Exactly why was the learning collaborative needed, right? Like what was the either the determinant or contextual factor that was, what was the barrier getting in the way, and how does this kind of link together? So I totally agree. We might be missing some information there of exactly, we don't have a statement of why they wanted to do this, right? Any other, so we've kind of gone through the gamut. Anything else that you feel like is missing? If you were to try to take this and replicate it in your study, what other information do you think you would need?
More about the specific population that we're giving.
Okay. And someone said they need to know the specific population they were giving this to, or this was intended for. Good.
Maybe the setting of the learning sessions and the one-to-ones, like are they in-person, virtual?
Yeah, very good. The mode of these learning collaboratives, are they bringing people in together? What are the logistics of that versus getting people together virtually? All right, very good. So we can see that this is a very common thing. I'm not trying to knock the descriptions, but there's so much more you could say, and maybe even using a table to really identify all of these elements so that we could improve the transparency and the replicability of our strategies if we wanted to take them and use them in another study. So very good. Good. Move on. All right. Thank you for that. So next, I'm going to transition us. I wanted to share a study that I've been working on. So I'm a co-I on a implementation science coordination center out of Northwestern, and they so what they do is they partner with anyone that receives an R01 from the Center for AIDS Research. There are these different hubs that help provide implementation support to these R01s that are trying to implement something around HIV, whether it's HIV testing, whether it's pre-exposure prophylaxis, or linking people to care, or getting people re-engaged in care. So this coordinating center helps synthesize a lot of information and provide guidance to the hubs. And so what we've done is we're actually doing a large series of systematic reviews to identify the implementation strategies that are used to improve HIV testing, so reaching folks, getting people on pre-exposure prophylaxis, which I'm going to explain to you what that is if you're not familiar, but it's a preventive intervention that is super extremely effective at preventing HIV contraction sexually or through drug injection. And so we're working on multiple systematic reviews, and I just wanted to share with you what's going on in the literature. How did we kind of extract information? How did we code implementation strategies? And then some of the findings from this study. So I just wanted to acknowledge ISKI and all of our partners and our funders. Pre-exposure prophylaxis is, as I said, a highly effective preventive intervention for HIV, critical to ending the HIV epidemic in the United States. There's multiple versions of PrEP that exist now. When we conducted this study, the daily oral pill was the most common form. There is a long-term injectable, a 3-month injectable shot that you can get. We're going to update this search with that innovation as well, but we really focused on the daily oral pill version. So as I said, PrEP reduces the chance of acquiring HIV sexually by 99% and drug injection use by 74%. So PrEP use has increased since it was first approved in 2012. But we're still only reaching around 18 to 23% of people who are indicated for PrEP. And so beyond reach, there's a lot of inequity around getting people who need it the most. I think so. Yeah, around like folks who are Latin, African American, or cisgender women or residents of southern states have much lower adoption and uptake and sustained use of PrEP. Okay, so we also actually conducted another systematic review to first identify what are the barriers? Why are people not on PrEP? So we identified a bunch of systematic or provider level implementation barriers versus patient level barriers of people because they have to take this pill every day. It's kind of on them to continue this adherence. So at the system level, there's a lack of awareness or knowledge of PrEP, who it's indicated for, discomfort or resistance to prescribing PrEP to folks, financing or available resources and lack of training. And not seeing a large enough patient base to keep up to date with guidelines around high quality delivery of PrEP. On the patient level, also low awareness. This has gotten a lot better more recently. A lot of self-perception, wrongful self-perception of being low risk for HIV. Having competing health priorities that make integrating PrEP into your daily lifestyle challenging. Mistrust in the healthcare system. So primarily, you'd have to go to a primary care doctor to get this pill, stigma around PrEP use, and then challenges navigating the healthcare system, and then remembering to take the daily pill. So in this study, we wanted to move beyond barriers, and we really wanted to identify what are the implementation strategies that actually overcome those barriers and get us to high levels of reach, adoption, and implementation and sustainment. So just going to recap really quick. We've talked a lot today about different change methods, and we first distinguished the intervention, the evidence-based intervention, which is focused on health outcomes, versus the dissemination implementation strategy, which focuses on adoption, implementation, and maintenance. So in our review, we saw so many change methods that were being referred to as a strategy or an intervention that didn't really fit perfectly well in either of those classifications. And I know we had a comment online earlier about somebody who mentioned, what about a strategy that focuses on like patient engagement? We see this all the time, especially with PrEP. It's somebody who has to go get their prescription and remember to take this pill daily because you have to, it's like more sensitive than birth control. You have to take this every single day in order for you to not be able to contract HIV. So there's a ton of strategies around changing patient level behavior, getting them to remember to take PrEP. There's a bunch of e-health programs trying to get people to learn about PrEP or motivating them to want to use it, helping them overcome stigma, having text-based reminders. There's also this really cool like capsule pill that would like, I can't remember what it did. I don't know if it vibrated, but it was something they wore on their neck to help remind them to take their pill. Or peer navigation or social communities to kind of bring down stigma and work together to just improve adherence and uptake of PrEP. So we, through this work, we came up with this new term of a change method called an adjunctive intervention. So this is something that targets recipients of a health intervention, and it's designed to increase their motivation, self-efficacy, or capacity for engaging with that health intervention. Initially uptake and then over time adherence. So this is something that's supplemental, right? Just if you get a text-based reminder to take your pill, that in itself does not get you to seronegativity, but it's something, it's kind of like an adjunct professor, right? You're that person that's kind of meeting in the middle and you're helping somebody engage with that intervention. So we actually wrote a paper about this method and really well specify the different change methods. That decision tree we had earlier was actually kind of taken from our adjunctive interventions paper. And we also have a presentation, and this, I think these slides will be available if you want to look up this paper or look at this talk. It's a really interesting talk about change methods that we delivered, I think it was back in 2023. Just to really clarify this, so this is a pathways to PrEP. So let's imagine there's a scenario with an STD or sexual health clinic setting that conducts HIV testing and offers PrEP. In this example, we see the clinic level implementation strategy, such as provider training. This links with an implementation outcome, adoption, reach, and fidelity. And the intervention PrEP is delivered to the patient to achieve a seronegative status. An adjunctive intervention, peer navigation, is also delivered to the patient, but is not directly impacting the health outcome. So it's not the intervention, it's an adjunct to the intervention. And it's also not improving adoption, implementation, or sustainability of PrEP. Paul would argue that it is part of REACH, which I totally agree with, but there are some other reasons I'm going to get into why we thought this other category was important. So this adjunctive intervention is supporting the patient and enabling them to receive PrEP or be adherent and stay on PrEP to help them be seronegative. Any questions about this before I move on? Yeah, back in the back.
Is the active intervention always targeted at the patient, or can it also be potentially targeted to like the healthcare provider, or like reminding someone in the that's involved in the intervention to do something?
Yeah, great question. The question was, isn't adjunctive intervention always targeted at the patient or recipient? And the answer is yes. So you could have like a reminder to a patient. You could also have a reminder to a clinician. We would call the reminder to a clinician an implementation strategy. So implementation strategies, everything having to do with providers and systems, and everything having to do with a patient is something a little different. Even though it's a very similar mechanism, we just classify it slightly differently because of the target of that change method. Then you had a question as well?
Sort of similar, but seems like I just wanted to understand that adjunctive intervention is additional intervention that basically doesn't reach to the final implementation outcomes, but somehow can affect intermediary into the final outcomes. Is that correct?
Yes. Paul.
I'd say with the exception that I know you used REAIM in one of your projects, with the exception of REACH.
Yeah,
So these
that's a good point.
interventions, depending on if you're operationalizing REACH as just enrollment or initiation or initial receipt of the intervention, then that would be one part of an adjunctive intervention, would be looking at that. I would kind of call it just a REACH strategy, but I think that it's fine to go whichever way you want to on this one. And then if you're thinking about REACH as a temporal variable, then all of the adjunctive strategies are focused on REACH, because it's something about getting them enrolled, getting them engaged and adhering, and then getting them to complete. And those are all usually, and they're things that are distinct from the evidence-based intervention. So it's if you have in the evidence-based intervention that you have, making the sessions engaging and following up and having peer partners so that you come back to the sessions. All of those things are still part of the evidence-based intervention that are also intended to improve adherence. And so this is where I think the adjunctive stuff gets a little bit, it's helpful, but it just helps to clarify feasible.
So it means that focus on REACH and it must be at patient level. From what you described, just in terms of adjunctive intervention, is that correct?
Yes, I believe so. Yes. Yeah, so an adjunctive intervention is not always necessary. And it's not all, or sorry, an intervention is not always sufficient. An adjunctive intervention is sometimes necessary. Okay. So the reason why, and I totally take the point that we can just call these REACH strategies and it's at the patient level. The reason why this was important for us in this study was and I'm going to get into this a little bit, but we were classifying the implementation strategies using this, it's called the ERIC taxonomy, which is a group of 73 strategies. We talked about this earlier, but this is a constellation. There's 73 and they were broken up into these 9 groups. There's a group of engaged consumers, and the only strategies in there were intervene with patients or consumers to enhance uptake and adherence, or prepare consumers or patients to be active participants. So because we had so many of these strategies, we were basically lumping them into this tiny category that was not descriptive. There were so many different things of how to get people to either start taking PrEP, remember to take PrEP longitudinally. So we kind of needed to use a different framework in order to capture these individual level behavior change mechanisms. And I'm going to talk about that in a little bit, but this is kind of why we shifted into this language and why we chose to do it for this study. So the objective of our study was to, remember, this is systematic review. We're trying to capture and categorize the implementation strategies and adjunctive interventions that have been used to improve D&I outcomes associated with PrEP. So we actually did this large, giant database search back in 2022 that we're constantly updating, but we pulled from that and we included only studies that occurred in the US, and they had to evaluate one or more of these change methods. So we had to go beyond identifying barriers or just describing and developing these change methods. So we kind of broke them into implementation strategies, as I said, if they focused on the clinicians or the system, and the adjunctive interventions if they're focused on the patient. So we coded each implementation strategy. We broke them up. There was a lot of bundled strategies with these big named things, and they had a whole bunch of stuff going on. I'm going to show you what that looks like in the next slide. But we tried to capture this nested structure of these discrete actions, who was doing what were they doing, what was the dose, and so on and so forth. We looked at the implementation outcomes, the study design, the setting and the population they were targeting. We created this health equity, health disparities variable because there's a lot of studies that specifically were focused on a specific population. There were some that compared a strategy that was adapted for a specific population to the general population. Some studies that identified a health disparity through their work, and some that were just, we're not really just aggregating data. We're just trying to get PrEP implemented like in the emergency department. We just want people to do it. We're not really focused on to whom. Then we looked at strategy specification, all of this information. Spoiler alert, nobody specified anything well at all. So we ended up dropping this, and this is a limitation. Like, people were not specifying these things really at all. The action was there, but that's about it. And then we just looked at effectiveness. Actually, from this study, we ended up creating an effectiveness rating tool, but we just used some really simple criteria: positive, negative, null, or no comparator available. And then, as I said, we coded to this ERIC taxonomy. So here I wanted to show you, this is an example of our coding. And this is a nested strategy. It was called the PrEP optimization intervention. So at this top level, that's the name, and everything's kind of lined up with this. Within that, there were this was another, like a nested within a nested. There was it's called PrEP RX, which essentially was like a workflow strategy. They created a dashboard that helped people see HIV risk assessments and reports over time for their patients, automated reminders to remind clinicians if they had someone who showed up who might need to be prescribed PrEP, as well as a website that clinicians could go to learn more about PrEP. As well as a centralized PrEP coordinator who gave trainings, who did all this other stuff. So we kind of nested these bundled strategies within each other. All right, now, so then this was a kind of a 3-level strategy here, nesting structure, and then we coded each of those actions specifically to the ERIC taxonomy. So then for adjunctive interventions, everything was pretty much the same, except instead of using that ERIC taxonomy where we were just lumping everything into engaged consumers, we used this other framework called the theoretical domains framework. Some of you might have encountered this in other places, or there's another framework that's kind of related called the COM-B. These are individual behavior change, based off of individual behavior change theories that really break into the specific mechanisms that these practices are targeting. And I'll show you what this looks like here. So it was either, so we'd look at like text-based reminders, and we code this to, is this improving skills, physical skills, knowledge, cognitive or interpersonal skills, memory, attention, or decision processes, behavior regulation. Those are kind of physical or psychological capability type of strategies. Then we looked at motivation, either reflective or reflexive or automatic. So identifying their social, professional role or identity, or helping them identify their group, beliefs about their capabilities, or beliefs about consequences of their behavior. If I don't take PrEP and I engage in this activity, if I can understand that if I do this, this can help me not contract HIV, kind of through that way. Improving optimism, looking at intentions or goals, automatically reinforcing by giving people either stipends or other rewards for doing it, or kind of talking about emotions. Then versus opportunities, the environmental context and resources is a lot in this domain where you're helping people put their pill on their nightstand, set a reminder, like all these things to help people remember to take this pill. Or social influences are also within there. So a lot of strategies were online groups, or helping people connect with a navigator just to give them some opportunities, bus vouchers to get to the place where they needed to go, things like that. And this is just an example of what this coding looks like. So an adjunctive intervention, individualized texting for adherence building, targets patients to improve adherence. And this was a nested strategy. I'm not sure, a nested intervention I'm not showing, but in targeted knowledge, beliefs about capabilities. So these are just kind of how we coded things. I wanted to share that. So it results. We identified 44 studies, 26 adjunctive interventions, and 18 implementation strategies. From this, we pulled out 122 discrete strategies and 156 like core components of these adjunctive interventions within their nested structures. So we found that 39 out of 44 were pilot or feasibility trials. So implementation science is pretty new in the HIV space. This was a couple years ago we did this. It is slowly getting better, but we're seeing just a lot of pilot trials. So we're hoping that these will shift into RCTs, but there's only 5 RCTs in the literature that we looked at. Most of them occurred in clinical settings, some in community-based organizations like churches. There was some in correctional facilities and other types of community-based organizations. Mostly targeted toward gay or bisexual men who have sex with men. A lot of studies looking at reach, some at adoption. Those were for the strategies. And then for adjunctive interventions, a lot on adherence. We talked about, just having people remember to take that pill or to start PrEP. Those were the main outcomes there. So there were 0 studies that fully specified their strategy. We ended up shifting the coding into like, how confident are you that this element is present? It's like not a great code, but we just didn't have any data to share. Like, I think there was like 4% of people talked about the actor. This is very low. And so we ended up kind of dropping that. And only 16 out of 44 had a positive effect on primary outcomes. So there's a lot of work to still be done in trying to improve on our strategies. 25 had a health equity focus. A lot of them were focusing on a specific population, and 10 of them identified a health disparity through the work. In terms of the implementation strategies, most of them were around training and educating clinicians to either be more comfortable delivering PrEP or know who's indicated for PrEP and when to deliver it. Some developing stakeholder interrelationships. This was like connecting. One popular strategy I'll talk about was trying to change who people have to go to get prescribed. Like, a lot of people felt really uncomfortable going to a primary care doctor who they felt either judged from. And so being able to just go to a pharmacy or get telementoring to be able to get prescribed PrEP. So there was like connecting. So you had to develop like a collaborative practice agreement for a pharmacist to be able to deliver PrEP. They had to kind of get trained, and essentially the prescribing physician would kind of sign off on allowing the pharmacist to make that determination. So somebody could go and get PrEP without having to schedule a primary care doctor or some other doctor visit. So yeah, here's kind of the breakdown of strategies. I won't belabor that. Here are some examples. There was one really cool strategy. It was called Getting to Zero San Francisco. It was a collective impact. It was an entire community trying to work together to bring different organizations together, bring different holders together to try to just essentially get rid of HIV. Like, we have the innovations to get rid of HIV. We just have to get better at getting it to the right person at the right time, right? So this was kind of a whole community effort. A lot of integrating PrEP delivery into other settings. So like, if you go to a syringe exchange program, you could get on PrEP, or at a reproductive health, you're kind of bundling it with other programs to reach people where they're already going. And then, as I said, pharmacies. I talked about the pharmacy strategy already. And I talked about the PrEP OI strategy already as well. So a lot of training modules, QI related, like PDSA cycles of slowly implementing adoption of PrEP into clinics, and then PrEP telementoring, which I already talked about as well too. I'm going to skip over this. These are just like the different domains. It was really interesting. There's a lot of different mechanisms of change inside these adjunctive interventions, where they're targeting multiple things with their adjunctive intervention. Not only are they trying to get people the knowledge they need and the skills, but like bringing people together with social influences, helping them set up their environment so that they can remember to implement, and so on and so forth. Setting goals, understanding, if I don't do this, or kind of motivational interviewing. If I don't do this, and this is probably my outcome, and that kind of helps people make that behavioral decision. So some examples of adjunctive interventions were motivational interviewing for PrEP uptake and adherence, e-health contingency management, text-based reminders, having nurses deliver an adherence intervention, online support groups, digital pill systems, peer navigation, and PrEP education. So a lot of things we've already talked about. Okay. So here's the discussion. There are a lot more adjunctive interventions and implementation strategies. I kind of already talked through these things, but yeah, change methods need to be better specified. And another thing that we've talked about as a group is if you have an adjunctive intervention, you might also need an implementation strategy for that adjunctive intervention, right? Like if you have like a prep education module that you need to deliver someone, you need to make sure that the person delivering the module is trained and that that's feasible. And so it's like this stacked thing where if you have an implementation strategy or you have an adjunctive intervention, you might also need to think about how am I going to implement this adjunctive thing. Okay. So yeah, future research needing to identify. This is one thing I really wanted to look at was, are there certain combinations of ERIC strategies working together that were associated with effectiveness? I didn't have enough power to do this, but it's something I'd like to do in the future to see if there's like constellations of strategies that cling together that really work well to achieve effects. And then standardizing or spreading the specification of change methods. Yeah, so as I said, specification is really low. Question?
I think it's super interesting that like, none of the studies you found like fully specified. Part of me wonders, is it like just kind of like a part of it is like just unfortunately like kind of the word constraints of like sort of like journals, and did you find like in the supplement that's where it's normally sort of found if one were to fully specify? Because I can imagine like, I mean, I'm realizing like the importance of really like, being detailed so that it can be replicable and generalizable. But I do wonder if that becomes potentially an issue, just like unfortunately just the way kind of journals are.
Yeah, the question was is if there was the reasoning for low specification was like journal word limitations. I think we speculated that that could be one of the reasons. I also just don't think that there's a clear following of a reporting guideline and no one really forcing people to do it or even recommending that people do it. Yeah, it's a good question though. Okay, I'm just going to wrap up. I think this is, and we talked about this. These are just like the promising approaches. I'll go through this really quick. Utilizing comprehensive equity-focused prep education training modules aimed at healthcare providers were really effective. As I said, there was not that many that were really effective. These are the ones that kind of rose up. Decision aids or risk calculators or automated reminders developed to support provider decision making when providing prep care. Those were effective. One thing that we see a lot is the integration of prep services into other settings. People really like those. A lot of the outcomes we're looking at were at acceptability, feasibility, or appropriateness, which I didn't really talk about, but this one was really appropriate. People really prefer to be able to get their prep care from someone else other than kind of your standard healthcare provider. Patient medication reminders, really effective. Prep navigators are a thing that are kind of being used within clinics. That was really effective. And then educational and support programs, social support programs for patients. Okay, that's it. I'm just going to share with you, we are working on, we had this up and actually got taken down once our spending freeze came in because we had some information on trans individuals on our systematic review dashboard that we had to take out and reclassify. So we are trying to have a massive dashboard of all of our systematic review findings where people can go in and search for studies related to a setting they want to target or an innovation that they're trying to implement, a certain population they're trying to implement with. And so all of this is filterable. We've actually written multiple other scoping reviews focused on like stuff for adolescents, stuff for people who inject drugs, people who use drugs, trans individuals. So this is a cool tool that other researchers can use, other providers can use to see what strategies actually work in the literature. It's not up right now, but we are working on revamping it and getting it back up. And that's available on the ISKI website, hivmsci.northwestern.edu. Okay, that's it for the systematic review. Any other questions about that? I know it was a lot. Yeah.
I'm curious if you can share a little more about your search methods, because a lot of the slide where you had all the numbers about like how many people specified things were quite low. And so I'm wondering, like, were these specifically implementation and dissemination studies, or are they studies that happen to be like, do they know they're doing
Exactly. That's exactly the question that we struggled with. And the question is where did we look? In our search strategy, did we really target implementation in either journals or people that use certain terminology? And the answer is no, because HIV and implementation science is very, very new. And so a lot of people didn't know they were doing implementation science, right? If I asked them like, are you an implementation scientist doing this? They'd probably say no. We did it, but we tried to do that at first and we really weren't capturing anything. So we had to expand to try to understand. We worked with a librarian to try to find like interventions focused on certain key terms around outcomes or, so yeah, it was tricky. And I think that's why we see a lot of low quality in terms of, if they don't know what they're doing, we can't expect them to follow a certain guideline that they don't know about. But we're trying to just bring awareness, like there are these guidelines and we need to specify things because we need to, have rigorous science that we can reproduce. Really good question. Paul.
Yeah, I think, we kind of ran into this like, 10, 15 years, maybe 20 years ago now, when we first were doing re-aim reviews of articles and people weren't using the framework. But the point is not necessarily about whether someone's using the framework or doing D&I strategies as their work. It's about replication of science, right? And so these things that we're talking about are just good science, right? Like just being able to specify this stuff to the level that someone else could pick the document up and be able to replicate what you're doing, or at least have a close proximity. And so I think that, that's how I kind of think about it, where, yeah, they might not have been doing this, but at the end of the day, if they're describing something that they've done and there's not enough detail, let folks know we need to expand on it. I have one question too, like when you did the systematic review, I know you said in the future you want to look and see it kind of things that clustered together and the outcomes. I'm actually not really even necessarily interested in the outcomes at this point. I'm curious to see if you found because in that area, there's probably a lot of community-based participatory research going on. And so I wonder if you just saw some consistent clustering of strategies.
Yeah, I can't remember exactly what those were. I know that we're working on a review about HIV testing and linkage to care right now, and I'm right at that point where I'm going to start that. But in the paper, I think I do at least talk about the different clusters. I for sure in one of our papers, I think it might be this one, where in the discussion we talked about which ones hung together, because I know I did that analysis. So I don't have the information in my head right now, but it's there. Yeah. Great question. Go ahead.
I think from what you described, you said 0 reported all of those implemented.
Right.
Yeah. Which made me concerned about reporting standard. Of course, you mentioned STARI, which I just looked it up. It's a reporting standard for implementation science.
Yeah.
My question is that since it was published in 2017, has there been any increased uptake of the way people should report implementation strategy, and if there is any particular strategies to improve the uptake of reporting the implementation strategies?
Yeah, I know the question is around STARI, which is a reporting guideline for implementation specific research that came out in 2017, and seeing if that's helped. I know certain journals require you to use the checklist, like implementation science communications, implementation research and practice. But if you're not publishing in a journal that doesn't require you to follow a certain checklist or a certain standard or guideline, so that's one of the strategies I've seen. I'm not sure, Paul, if you have any other insight into whether STARI helps or what else we need to do to improve our reporting and implementation research.
It feels like a bit of the kind of just the spiral, we have guidelines that we also need to implement on our reporting of implementation strategies. And so I think that to me, the place for intervention around strategy utilization is really with the journal editors that, if they are requiring those things on submission, then they get done. If someone we use STARI, but I don't create the STARI flow diagram stuff unless it's required by the journal. And so then that means that there's probably some papers that we write that we don't hit everything because you're worried about word count or you're worried about this or that. So I think there's the strategy for that one is really at the journal level.
I think it comes back to what types of journal. And as you mentioned about implementation science journal, they require STARI, but other journals that actually a number of health services research involve implementation. So the community of health services research and other people that should have adopted implementation strategy to be reported haven't really used it. So it comes back to thinking about strategy to convince those journal or maybe communicate them somehow to ensure that this kind of story should be incorporated, or if there is any basically other reporting guidelines that should be combined. Basic story should be kind of selling story idea to other reporting standard guidelines so that the implemented strategy are more specific. Anyway, I'm just feel like it's a waste of knowledge that has been done without good science. So I mean, it's good to see that dashboard, but again, I'm worried about the fact that if we don't have a good foundation in terms of reporting, it's not gonna move much because the lack of information. That's all. Thank you.
Yeah. And I'm also curious, like if because these were pilot feasibility trials, like if in the future when these are tested and fully powered RCTs or whatever type of design you use, if those would be more rigorous and they'd be required to provide more information. I don't know if that's anything, but I didn't really compare like if you write an RCT, do you need to have that as part of the study, the description, or if that's really still a free for all? I'm not sure.
Consort was developed like 1998. Quorum was developed 1995, and Prisma generated in 2002 or something. So it took like now it's
Sure.
25 years from Prisma, or even 22 years from Consort.
Yeah.
And I don't know, but it seems pretty obvious for them to adopt that. But I think it's important to think from the implementation side, community, what kind of strategies, how to convince other journals or other reporting standards to include your story stuff as part of that. I think that's
I know like
stuff.
the Implementation Science Journal, no matter what type of study you're doing, they provide you a resource of where you can search for, depending on your study design, what you're doing, which guideline should you actually use. They direct you to this and they say, pick the appropriate guideline that you need to for whatever you're doing. And I think you have to write it into a letter justifying why that guideline, even when you submit, I think it's part of one of your supplemental things. You have to indicate what guideline did you use and why. I don't know if it's that intense, but I know you at least get to have the opportunity to find the right guidelines. So that might be a good practice, but I totally agree. That's one way to tackle this. Okay, any questions online before I move on to kind of our last segment? No? Okay. Feel free to put those in the chat and Toby can relay. Okay, so I believe this is the last segment, is I wanted to share with you some tools and methods for developing, selecting, and tracking strategies. So there's a whole bunch of tools out there. There's some that our CTSI have been directly involved in developing, so I wanted to share some of those. So for identifying strategies, you might be wondering, so, okay, there's all this stuff, but how do I identify strategies? So there's a ton of different methods. There's one I'm going to share with you. It's really like a human-centered design engagement with your implementation partner. There's some really good protocols out there using either co-design or modified Delphi. There's another method called a group model building, which takes from system dynamics, and you work with a group to understand, you use causal loop diagrams to really identify you could use it to identify what strategies work within this system where you're working with your partners to identify those things. The implementation research logic model. Can I see a show of hands? Who's heard of the implementation research logic model? Okay, so just a few. So this is something that was designed by J.D. Smith and his colleagues. He's here in population health sciences. It's a really great tool for prospecting about your theory of change. I'm going to show you what it is. You can also use that. I'm going to show you an example where they use both the engagement with their implementation partners and an IRLM, but it's just a logic model. And it's really similar to what Paul showed earlier with the Cosmos, where you have your context in a column, your strategies, your mechanisms, and your outcomes. It just is a logic model that helps you link across my strategies working through this mechanism to achieve this outcome based on this contextual factor. So I'll share that with you in a second. There's also it's called the CIFAR Eric matching tool. Who here has heard of CIFAR? Okay, almost everyone. So there's this, it's not a great tool, but it's a novel effort to try to help you if you have done some contextual assessment with your partners of what are the main barriers that are going to get in the way of implementing. It helps you map those onto which strategies from the ERIC taxonomy are the kind of the logical link for where you should kind of start to look in what constellation of what strategy maps onto that barrier. And there's a link for that there. Paul is going to share the iPrism tool and some resources on the Reaim website. Not now, I think we'll get to those in a minute. Then there's another, so that's kind of all identifying. Then there's a really structured process or method that's been developed for if you want to just from scratch develop your implementation strategies, and that's called implementation mapping. It's based off of intervention mapping, which is a very structured step-by-step way to develop an evidence-based intervention, just an extension for implementation strategies. And then another tool that I have been developing with colleagues is a method for specifying and tracking strategies over time. And I'm going to talk about that one. It's called lists, but that one's freely available as well. Okay, so for the partner engagement, I wanted to just share this. This is a really streamlined version of a partner engagement strategy for identifying strategies. So first, you work with a clinical partner. This is in this study. They were trying to implement toddler social emotional risk screening, and what they did is they created a clinical partner working group, and they met I think 3 times or 2 times. And what they first did is they had individual interviews with these folks, trying to understand the usability of testing in their setting. So they did these interviews and then they generated all of these contextual barriers, and then they met at the meeting to generate potential strategies. So they took that information, created, I believe, just like a list and brought it back to that meeting. And then they talked together of here's all of the barriers. What are some things we could do to overcome these? So they really worked together to co-design and generate these strategies. Then after that, they met as a research team. They took all the barriers and they took all the strategies and created a matrix and tried to match onto what strategies go with which of these barriers. Then they brought that back to the clinical work group and they had them kind of start to filter down which of these strategies are most feasible. They had them specify each of them. As I said, like if you want people to really think critically about what strategy is going to work, make them sit down and specify, because they'll start to put names to who's actually going to deliver this at what dose. And they'll start to say, oh, there's no way I could do that, or absolutely, this is something we can do. So they work together to kind of trim down the strategies and then specify the ones that were most feasible. So after that, they then, I believe, met as a group and sent out a survey of, I think they sat down and created ratings and then sent that out as a survey and had them indicate the relationships between the determinants and the strategies. And then together they built an implementation research logic model, which I'm going to share with you now. So this probably looks really, really similar to what we looked at earlier. So this is where you can really just draw out your causal plan of change. It could be for planning, it can be for executing, reporting your study. But this is where you can put all of your implementation strategies. You kind of start with what you know. Say you're working with a community and they really want to focus on a certain outcome, like they want to improve reach or they want to improve adoption. So you can either work from outcomes, then maybe you do a contextual assessment and you look at what are the barriers getting in the way. That can help you select your strategies, and then you kind of determine through what mechanism is it going to work. So this is just it can be used for planning, multiple purposes, but it's a really good way to just map out all of your strategies and how you think they're going to work. You can also include your clinical intervention here. But from that study I was sharing, this is actually from their paper. This is the implementation research logic model they came up with. I know this is a lot to look at, but there is some color coding. You can see that the superscripts, the A matches up with a specific set of determinants. And this is what the partners actually help them do. Map the different strategies. Which barrier is this strategy actually targeting? And then you can carry that through all the way to outcomes. So through what mechanism, I don't want to overwhelm you, but this is just something, this is what it can look like. You can use color coding, superscripts, subscripts, just to draw your theory of change across the board. Okay. All right. So that's it. Any questions about that?
And if this looks somewhat overwhelming, like for the figure that I showed you guys earlier that was just had like context, one strategy, a couple of mechanisms and the outcomes. That came from a table or a logic model that looks almost exactly like this, that we use lettering and all that kind of stuff. So when you're doing this with partners, usually you don't have all this stuff.
Right. You would never show them
Kind of
something like
book.
this. Yeah.
So yeah, so don't, but it also ends up being a really nice way for you to communicate what you've done later in an article where you get a lot more detail. You know, like you guys said, when you saw the one strategy that we have a couple of paragraphs on it, but when you put a table or a logic model like this together, you get a lot more information that's visually pretty clear. And even though it looks overwhelming, someone looked at it and said, oh, I'm just going to look at the C lines across here and I'm going to see where everything goes across linking, and it just becomes a lot easier it's just another way to communicate.
In terms of putting this into a manuscript or a paper, I'm imagining you don't discuss in the paper all of this. So how do you select? Like, how do you decide which is the most important things? I guess, is it just depending, on your project and what you want to highlight? But I'm guessing this is way more detailed than you're gonna actually put in paper. Maybe not.
That's a good question. You're probably right. You couldn't. This is a really good way to show your theory of change. You might. So this is instead of having to write it all out, you can refer to this if there's specific things that came out. I'm not really sure how to answer that though, because I think you want to be really clear of what are you doing and why. And so I think this can not only help, but I think you could also, if you wanted to, really write out exactly how this came about and what are the specific links, but I don't think you have to. I think you can refer to it. Paul, does that sound about how you've used it? Do you feel like when you use your IRLM, do you also write out exactly everything?
Yeah, I'd say that if we were using a figure like this, we'd probably have a little bit less text. Like, where it's all the family buy-in, family circuit, but like we'd probably condense that down here, but we'd have a paragraph that talked about our family level contextual factors. Like we would have that in there. So I'd say that we still write a lot to this.
Yeah. And I know these can be extremely helpful in grant submissions to really clearly show your theory of change because reviewers tend to love these, I hear. Yeah. All right. I'm going to move us on. I'm just going to show you really quickly what the C4ERIC matching tool looks like. It's actually a macro, so you can actually go in on one of the tabs and select which of your determinants or your contextual factors were identified as barriers, and it'll spit something out like this, which of the ones map onto. I don't want to, this isn't that great of a tool, but it is something that's available. And then Paul, did you want to talk about the iPrism web tool?
I think we can just very quickly, the idea here is that this is a tool that's based on the PRISM framework and REAM framework, and it's intended for you to use with a community or clinical partner. So I'm not going to go through it in detail. You guys can go ahead and if you get the QR code, that should take you to the website, or it's just www.prismtool.org. But it's a really nice way to map out a full project. And part of the process is it will help you to identify strategies. And then when you click on it, it has strategies mapped to PRISM mechanisms, and then it has strategies mapped to REAM outcomes. So it's kind of a nice, because it comes with some of that mapping already embedded in it.
Great.
Oh, and there's some of the tables with the embedded mapping of strategies to REAM. So,
gotcha.
and I have to give Katie Trinkley credit because I pulled this directly from the presentation we did together.
Okay, the last tool I'm going to share with you, this is something that I've worked on developing as a postdoc. I didn't come up with the idea, but I've worked on developing the tool. So this is called LISTS, the Longitudinal Implementation Strategy Tracking System. And so in implementation science, as we've talked about a little bit, but there's not only a lot of gaps in implementation science, there's also an explainability gap. So if you have like a 5-year trial and you come up with your implementation plan. Maybe you have an IRLM, you have all these strategies that you think are going to work through a certain mechanism to achieve an outcome. During the trial, there's not a lot of stuff that happens to talk about anything that changes, any modifications or adaptations you make to those strategies. If you have staff turnover, if you change the dose of something for some reason, if there are emergent barriers that come about, like for instance, in a study that I work on with Paul, SNAP-Ed was funded, and SNAP-Ed was a program that was helping us implement a certain component of our intervention, but it was a huge adaptation that we had to track. And so this program helps kind of open up this black box of what strategies actually achieve the outcome, if they change or if there are modifications over time. So this tool just helps you specify at the beginning all the things we've talked about with your strategy, then over time meeting on a regular basis to meet with your team to discuss if anything has changed, what changed, who decided to make the change, if it was planned or unplanned, and then why. So we use this timeline follow back procedure just to, instead of at the end of the study, 5 years later, trying to figure out all the stuff that changed and what implications that has for our evaluation, this just gives you some more data to just more clearly show that theory of change. I'm going to kind of walk through this. There's a lot of modifications that happen. It really leads to a lot of problems in implementation science, lack of rigor, lack of transparency, and lack of reproducibility, because you can't really replicate all the changes that happen during a trial. So lists aids in the specification and operationalization of studies at your study onset, helps you reliably capture dynamic changes over the course of time. It can produce data that can be compared, synthesized, or reproduced. You can do sensitivity analyses, like if this didn't happen, or if this did happen, this is how the outcome would have changed. It can also increase rigor while balancing pragmatism. Oops. Okay, so lists can be used to track, you could also use this to track fidelity to each of your implementation strategies. So we've talked about fidelity at an intervention level, but there's also fidelity at the implementation level. If somebody's delivering a strategy, we need to make sure that they're delivering the strategy as it was supposed to be delivered. So this can help you track that. Like if you are a trainer and or maybe you're doing like facilitation and you're going into a site and you're delivering adaptive support to that site, and you don't go as much as you are supposed to go, or you don't do as much as you're supposed to do, that would be a protocol deviation that you'd want to capture. Lists can help provide depth to your analyses. It can help you determine whether the primary outcomes you thought were going to be affected were actually achieved by those strategies. As I said, you can do tests of adaptation or sensitivity analyses. If you have a study that has multiple clusters, or you have multiple clinics or hospitals that are kind of being rolled out, you can demonstrate balance or imbalance across those clusters. It also helps you with implementation costing. You can do time-driven activity-based costing. If you know the actor, the dose, the temporality, and the duration of how long they're doing it, you can just add their salary information and you'll have activity-based costing. Okay, so this tool is available on this website. It's really cool. It's really fun. You can like enter all your strategies and it spits out this really cool interactive dashboard. So this is a study where we've added a whole bunch of strategies. Each horizontal bar is a strategy. If they're still active, they're in blue. If they've been modified, there's a yellow dash that lines up on this timeline. You can bundle your strategy. So we have this strategy: assess context, needs, and determinants. And it has a bunch of all the discrete strategies within it. If you click on these strategies, it shows you information. This is all the specification that we've talked about before. The name, whether it's part of a bundle, the actor, action target, all this information is right here. And then you also can modify or track strategies here. And you can't see it, it's kind of cut off, but you have a modification log at the bottom. So this is an example of an export. I just wanted to show you what data you can actually get. So you can get all of your information in a CSV file. And this can be really good for your evaluation paper. Okay. Let's see how we're doing. I just have a couple things. I feel like I'm just droning on here. This is brutal. But there's a couple other tools I wanted to share. Another set of folks I work with, when we were trying to, if you think back to when I shared my paper talk, we didn't really have a good classification for whether or not this strategy was effective. So we're actually developing a best practices evaluation tool that you can access online. It allows you to, it gives you a score of, it assesses your study design rigor, whether or not you had an equity focus, and it kind of gives you these different categories based off of whether it's a best practice strategy, promising, more evidence needed, or not recommended. So it's kind of like if you're familiar with the What Works Clearinghouse in education, like a compendium of effective strategies, we're trying to create a compendium of effective implementation strategies that can be generalizable across different contexts. Okay. That's it on tools. I had just one last section on study designs. Any questions about the tools I shared? Okay, I know we're almost done. I'll kind of rip through this last part. So, in implementation research, we really focus on testing strategies versus testing an evidence-based intervention. So it's just a shift in focus. But when we do this, we're trying to evaluate implementation outcomes associated with strategies. So we have a very similar study designs to ineffectiveness research, but this does change a little bit and influences what we measure, what to test, how to test, and what to evaluate. So there's some really interesting study designs. I'm actually just going to skip through this and show you these rollout trials. You might be familiar with a stepped wedge trial, but these are really, really popular implementation research because we often are trying to roll out these different strategies into different communities. And so there's a bunch of different study designs that are unique to implementation research in these rollout phases. I don't know if that's actually true, but I think it's been applied in implementation research a lot more frequently. And so there's a lot of different ways where you can roll out different strategies or different interventions in different settings to test which strategy is most effective. So you can do this in like a 3-phase rollout where you have a control. So each of these bars is a different site. So you start in control, and this has a comparison not only over time, but between different sites. So you have multiple experimental, what am I trying to say? Kind of tests of experimentation. You can also do head-to-head rollouts where you're kind of rolling them out. You're doing 2 different strategies in 2 different sites, and you're comparing the outcomes there, and you're rolling those out in pairs. There's a whole bunch of different rollout designs, but that's kind of a really interesting place where we've been innovating on study designs. Okay, I had this last slide. I don't think it's relevant, so I'm going to skip it. This is just I'm going to skip it. All right. Thank you so much. I know this was really long, kind of a little more didactic than probably we want it to be, but thank you all so much. Are there any questions or things you want us to discuss? We've got about 15 minutes. 10 minutes. Oh, is that right? Yeah.
15 minutes.
Okay, cool.
About 15 minutes.
Awesome. Yeah.
Do you guys have strong feelings on the ERIC strategies? Do you like them? Or when do you not like them?
I can start. My feelings toward them have shifted. When I was really early, I thought they were really helpful. I think they give you it helps us like when we're trying to capture what's the essence of the strategy. It's good to be able to categorize it into a certain bucket, but it's not sufficient, right? Like it's not nearly enough information because there's a lot of things that can be within the same ERIC category, but look very different or have very different actions and things. So I think it's helpful until it's not, is my answer.
Yeah, I think I would concur with that. As somebody that does primarily community stuff and a little clinical stuff, it's very, very healthcare centric. And so there's a couple of additional compendiums out there. There's a school focused one. There's one that's community focused. And like James said, I think all of them are helpful. I think there are good ways for you to communicate the things that you're doing, and they're good ways if you're using the labels for us to summarize literature, be able to get a sense of what's going forward. I don't think they're great to help you do specification. I think there's a lot of overlap. There's, something like what was the one that I put at the beginning that was like engage, consumers. Like there's so much stuff that you could be doing around engaging consumers that, could easily subsume a lot of other strategies too. And so I think that if folks are familiar with the behavior change wheel, where they basically just kind of identify what are all the things that you could do. That's kind of what the compendium is. It's not an evidence-based list. It's not, but it's somewhere that you could say, oh, I'd like to pick this component, this component, this, put it together, and then label that. So I still think it's helpful, but it's, you know, I don't think it's the end of the world if you don't start with those even.
Toby?
So there's a question from Ben. So he said it's been involved in some grant writing opportunities, and sometimes on grants where a new intervention has been proposed. However, it seems that DNA science is more about interventions that are already proven to be effective. Can these frameworks of testing strategies be applied when designing an intervention trial as well?
Yeah, great question. There's not the next workshop, but the workshop after it is going to be on hybrid designs, which it's a hybrid effectiveness implementation approach where you're doing a little bit of both. So there's 3 types. The first type is where you're still trying to gather evidence for your intervention while also collecting information on implementation. So then once you start to, you kind of go through that, you can move into a hybrid 2, which is really testing both the intervention and your implementation strategies. And then a hybrid 3 kind of shifts more to an implementation where you're really testing implementation strategies while also collecting information on the effectiveness of your intervention. So hybrid approaches are a very popular way to kind of, in what we've been talking about, like early identifying what's going to work or what's needed for implementation, as well as trying to establish it as evidence-based. It's a little bit interesting, right? Because you want to make sure you're implementing something that's effective. So I don't think you want to just like, and maybe Paul can speak to this more, but I know we're going to get into it in hybrids a lot more, but generally in implementation science, we want to make sure we're disseminating things that we know work. We don't want to disseminate something that we don't know if maybe it'll work or maybe it's risky. And so I think that's where you might do a hybrid 1, where you can start to collect what are the challenges that came up in implementation? What are the barriers? What are things that people think might help them implement it or might help spread it and scale it? And so starting with a hybrid 1 can be, I think, a really good entryway into establishing that effectiveness while also understanding how it needs to be implemented.
Yeah, I think that's a great answer. And, you know, just kind of with the falling back on, 25 years of using REAIM over that time, we have papers at the beginning where it's like, these things are important, whether you're doing efficacy research, effectiveness research, or at that time we were calling them demonstration projects, and the idea is that we always want to have a good sense of the population that you're trying to engage in an intervention and how well you're able to do that. We always want to have a sense of how well this thing is working in a new context from an effectiveness standpoint. We always want to understand the context of it, the adoption setting. Who are the people that are going to be delivering the intervention? And we're always interested in the process of implementation itself. And then we want to think about, how would these types of things be maintained? So back then, we wouldn't have called it a type 1, but that's exactly what it was, right? It was like gather all the information around it as you test something for effectiveness. But I think the main point is that when we talk a lot about dissemination implementation science, if you're writing a grant, you have to have an evidence-based intervention. And if you don't have that, you're not going to get anywhere with this type of field. But I would say that all of the principles that we use in dissemination implementation science are very applicable to designing a brand new intervention from scratch. And so you can still use these types of things there. It's just, if you're writing a grant, you can't be trying to come up with a brand new intervention that's intended to improve health outcomes and expect it to get funded through a DNI mechanism.
All right, we did have some closing slides. Liz, did you want to share these things?
Thanks so much. So just before we close here, I'll do a quick plug for the Dissemination and Implementation Science Core. So for those who are not familiar, DISC is part of the CTSI, and we offer consultation to researchers at the U for preparing proposals
implementing proposals or projects. And so you can find out more about our services at the CTSI Triad website. There's a request form that you can submit through Triad, and basically we'll meet with you and understand how we can better support and help your work related to dissemination and implementation science. There's another quick plug. We also offer a graduate certificate in implementation science. So these are the courses for that, and there's a website linked here you can access for more information on that.
Oh, and it's not up yet, but we're gonna do a theories, models, and frameworks graduate class in the spring that will
Nice.
also count towards this certificate.
Awesome. Thanks.
We'll try and send that out.
Awesome. And I'll add that to the slide here. We also offer, as part of the Mountain States Partnership for Community Engaged Dissemination and Implementation Science, there's a year-long mentorship program, MS SETI. And typically, the application for this program is open in the spring. I realized now I have an error in the dates there to be 2025, 2026 cohort. It will be available in spring 2026. Sorry, we're way ahead of what's on the slide here. So, for those who are interested in subsequent workshops, we'll have this plug as well. Again, typically the call for applications goes out in early spring. And Paul and James are very involved in that. There's a didactic component and then a year-long mentorship component in D&I research with a community engaged focus. And then finally, please take a few minutes to complete the evaluation form for this workshop. As James and Paul mentioned, we have 2 more workshops in the upcoming academic year. We will continue these workshops beyond that, and we're always looking for topic ideas. So if you have something that you'd like to learn more about, there's an opportunity on the evaluation form to provide, in addition to feedback on the workshop, to provide ideas for future workshops. So I will leave that up there. And I just want to say, so thank you everyone for coming in person today. Thank you for those who attended online. There is lunch available right now for those who are in person. Even if you can't stay, please feel free to grab a box to go or a sandwich to go. There's plenty for everyone. And so with that, I'd just like to thank Paul and James again for presenting and look forward to connecting at lunch.